I'd like to invite up Dr. Dadras, who is an associate professor in dermatology, genetics, and developmental biology at University of Connecticut Health Science Center.
Good afternoon. Pleasure to be here. Thank you, Stan, for inviting me. So I just wanted to, as a way of introduction, just wanted to tell you how I came to this field. When I was a pathology resident at Massachusetts General Hospital, I had the fortune of working with Michael Demar. I did my postdoctoral work in his lab, and I was fortunate to work with Marty Mim and Paula North, and that's when I got interested in vascular anomalies. And there we had a vascular anomaly clinic where we saw patients, and we worked with the ENT doctors and dermatologists and pathologists trying to come up with the best diagnosis for our patients. So today I wanted to talk to you about contribution of lymphatic pathology in vascular anomalies. So how do I advance? Just click. Okay. So classically, the vascular birthmarks have been doctors Mulliken and Glowacki have really provided a framework upon which we still classify vascular birthmarks. And they're typically divided to vascular tumors, many of which you already know, and I'll touch upon campyliciform hemangioendothelioma today, and vascular anomalies. So it is this framework that is currently being used. And I invite all of you to actually pay a visit to this website. It's a great website from the International Society of Vascular Anomaly that shows classification for vascular anomalies. And again, as you can see, it's based on vascular tumors, which they're divided to benign, locally aggressive, or borderline. That's where campyliciform hemangioendothelioma lies, and of course, malignant like angiosarcoma. And vascular anomalies are themselves very interesting, but not as well studied, and I'll show you some results today. Where they can be certainly combined. They can be both vascular and lymphatic, or some of them they can actually have very high flow, such as arteriovenous fistulas and arteriovenous malformations. So today I'll briefly introduce the basic lymphatic endothelial biology, and mostly really focus on lymphatic markers, because the last two speakers, especially Stan, did such a great job of describing the biology. But what I will get into is the venous lymphatic malformations, and show you a couple of pictures of a couple of patients of this case series that we haven't published yet. And I'll talk to you about the role of PROX1 in making a diagnosis of campyliciform hemangioendothelioma. So this picture you saw previously, this is how I came to the field, because I was interested in skin biology. So skin really provides a great model where you can study all the vasculatures. These are the capillary size. So in skin we have the superficial venous plexus and the deep venous plexus. So they're composed of arterioles shown in red, venules in blue, and lymphatics in tan. And it shows how they might interact here in the deep portion, and of course the capillary network. So the deeper vascular plexus and the capillary network we just talked about. So this is a very simplistic cartoon, but I think it makes the point where the basement membrane is discontinuous in lymphatic endothelial cell. In fact, there are these overlapping junctions, and the endothelial cells are actually tethered by these anchoring filaments. So under increased interstitial fluid pressure, these gaps open, and that's where macromolecules and fluid, and of course, as you heard, some of the lymphatic cells will enter. So clearly, lymphatic system has a significant role in drainage of interstitial fluid, return of fluid to the blood vascular system, attraction of dendritic cells and immune systems that you heard about, and of course, pathway of lymphatic tumor metastasis, which is something that I was interested in. So how do lymphatics come about? It was actually in the beginning of the 19th century where Sabin proposed that there are actually pre-existing primary lymph sacs present throughout the entire human embryo. And of course, the current model is that we think that and perhaps this is a little bit of both, perhaps some of the more modern approach and pre-existing evidence of primary lymph sacs. But as you heard, PROX1 seems to control the lymphatic fate. It actually, it is thought that here in the lymphatic bias, the cells that actually express lymphatic phenotype or lymphatic specific genes do arise from pre-existing veins. And of course, from lymphatic bias, these cells acquire lymphatic specification, and at this point, they express a higher level and of course more entirely of the lymphatic specific genes. And of course, that's where they take off. The PROX1 positive cells take off, and they can actually go to other site and set up shop there and make the lymphatic network. So this is an actual data showing how this idea came about. So that's just so this is a mouse embryo section. It's a spinal cord section, very beautifully done. This is a knocked-in LAC-Z PROX1. So what it allows you to do, it allows you to see and stain the early lymphatic cells that are PROX1 positive. And of course, they'll also be LAC-Z positive, so that's why they're blue from cardinal vein. And you can see from the mouse cardinal vein, and this is around day 10.5 of gestation. So that's where the cells basically take off. And of course, this is shown in immunofluorescence, cardinal vein again. And you can see not the entire parameter is actually lined by PROX1 cells, but perhaps only about a half, as shown in the previous cartoon. So the health and maintenance of both blood vessels and lymphatic vessels are very important, and this is only a very limited picture. As Stan mentioned, this only captures what we so far know about vascular endothelial growth factors and the receptors. So for the sake of the argument, which this would lead to the specific markers that I will discuss shortly, is that to keep in mind that VEGFR and 2 are typically expressed on blood vessels with neuropilin 1, and of course VEGFR2 and 3 and neuropilin 2 are lymphatic. And of course there's a lot of crosstalk, so these are not mutually exclusive. So the ligands can activate. So for example, VEGF-C, there are examples where it's been shown that VEGF-C or D can activate VEGFR2 on blood vessels. So this is a more recent table showing all the available markers to pathologists and biologists alike, where we can actually study these vessels more specifically. So I just want to direct your attention to LIVE-1, which has been discussed. It is predominantly expressed very specifically on lymphatic vessels in this particular context and not blood vessels. And as shown here in skin, again, superficial venous plexus and the deep venous plexes, you can see the LIVE-1 is shown in green. And of course, CD31 is what we call a panvascular marker. Now, when you use immunohistochemical stains or immunofluorescence, you'll see that CD31 is predominantly expressed on the blood vessels. But when you look at the messenger RNA data and gene transcription profiling, you know that CD31 is also expressed on the lymphatic endothelial cells. So that's why you can see some of these vessels that actually turn yellow. And that's because these are lymphatic vessels, which I believe express both a little bit of CD31, but a lot of LIVE-1. And of course, green and red would equal yellow in this context. And I wanted to talk to you about PROX1 more specifically. So this is a section that we performed in the lab, immunofluorescence, looking at Kaposi sarcoma. You can see that PROX1 specifically stains the nuclei of the tumor cells. And of course, LIVE-1 shown here in green, this is just a normal unremarkable human duodenal section showing numerous lymphatic capillaries or sacs in the lamina propria. So now to show you a couple of examples on how we use this in diagnostic pathology. So this is a section, this is actually, this was an excision of a 3.5-year-old tongue. It was a partial, rather excisional biopsy showing lymphatic malformation. Here at this low power, you can see its mucosal surface, but you can also see that it's, there are numerous abnormally dilated lymphatic spaces filled with pink proteinaceous fluid, that's endolymph. You can also see salivary glands shown here. This is higher power. You can see the same dilated vessels, very similar to the pictures that Stan showed from lymphangiomatosis in the lung. Also surrounded by mostly lymphocytes and histiocytes. So when we apply LIVE-1 in this study, you can easily identify the capillary size, strongly expressing LIVE-1 in the capillary size, smaller ones. But you can also see, you can actually detect a little bit of LIVE-1 expression in the larger ectatic vessels as well. So here's a higher power magnification. It's not very strong, but you can still see a very nice, very thin, delicate highlight of it. And this is in contrast to the capillary size lymphatic. And of course, when we apply PROX1, as you all know, it's a transcription factor. It specifically highlights the endothelial cells. This is another example of cutaneous trunk of a 5-year-old female. This was diagnosed as microcystic lymphatic malformation. Now, when you look at this, you know that the surface of skin is abnormal. For one thing, it's papular, and you can almost picture in your head that this would be what would be called fish eggs clinically. So these are sort of clear fluid-filled vessels that would appear on the skin. And of course, when you look closely, you can also see some of these more dilated vessels or lymphatic spaces below. And so here's a higher power magnification of the more superficial abnormally dilated lymphatics. You can see this is very beautiful, and remember the actual valves that Stan showed that are supposed to be very deep within the lymphatic structures? They're actually present in the superficial lymphatic, so that's completely abnormal. And of course, this is in the lymph. You can also make out a few lymphocytes at this power, and these are more of the deeper lymphatic spaces. Again, you can see they're surrounded by lymphocytes. So that, again, I think suggests the close, intimate relationship between lymphocytes and the lymphatics, even in a lymphangioma. So really quite remarkable. So we can actually see that LIVE-1 highlights very nicely, again, these larger vessels, same picture that I showed before, same field. And LIVE-1 also highlights these more deeper structures, again, lymphocytes within the lumen. And this is PROX1 highlighting the endothelial cells. And PROX1 highlighting the endothelial cells in the deeper vessels. So the summary of our study was that, so we had a mixture of mostly children that had a mixture of mixed lymphatic and vascular malformations in contrast to pure venous capillary malformation and, of course, port wine stains. And when you compare and contrast, you'll see that the malformations, most of them that had lymphatic component, of course, they expressed one of the lymphatic markers. You can see most of them did, and CD31. But this is in great contrast to venous capillary malformations, which were completely negative for any of the lymphatic markers, and of course, port wine stains. Port wine stains, I don't have a picture to show you, but of course, you'll expect lymphatic markers not to be expressed in port wine stain because port wine stain is purely blood vessel problem. So there are a couple of more difficult cases that I'd like to show you how we actually use lymphatic markers to make the diagnosis. So one was the case of a 25-year-old, this was the patient we had at UConn, 25-year-old male with duodenal mass. So of course he had intermittent duodenal bleeding since 2002 and some blood loss more recently. So of course the EGD demonstrated some duodenal polyps. That's as much as we got. And of course he had the abdominal CT that showed this. You can actually see he had two actually, but this is one of the 2 centimeter filling defects. So the CT impression was that there are 2 filling defects which could represent duodenal polyps, and that's all we got. Until I received, actually this was in the OR where I received the polypectomy from the duodenum, and you can see that by no means is this a typical neoplastic polyp of the intestine. It is lined by duodenal mucosa. There are Brunner glands, but of course what the pathology here is numerous abnormally dilated structures, some of which are perhaps more thick-walled, some of which are more thin-walled. So a closer view showing the same thing. Again, endolymph, lymphocytes within the lumina. So this is CD31, and it's always striking when we see this with the residents around the scope. that it just lights up like Christmas tree, and you can see how many CD31 positive structures there are. If you notice, you can see that it is actually in some of the vessels, you can see it being expressed stronger. I think that is a true that's a true vein, as opposed to some of the ones that are more lightly expressing, and those are the true lymphatics. But as I said, CD31 is a panvascular marker, and this is a higher power showing the same thing. And so we took the same section and stained it with D240 or potoplanin, and you can see that it's highlighting some of the capillary size lymphatic spaces more strongly than the more dilated ones. And here's a closer view of that. Notice that it's both luminal and abluminal expression of LE&RN, and of course lymphocytes that are very clean, not expressing. So we made the diagnosis of duodenal lymphangioma. This is a much more complicated case, and I was fortunate enough to be working with an OBGYN at the time. I was at Stanford, and that's why I met Stan, and I was fortunate to work with him as well. So this was a case of a 42-year-old African-American female. She had a very complicated history of stage 1B cervical squamous cell carcinoma 9 years ago, followed by lymph node dissection and XRT. So for the 4 years prior to what I'm going to show you, she developed these warty lesions on the vulva, and no one really knew what they were. They were called anogenital warts. She was treated with Aldera, and of course, it worsened the situation. She developed severe pain with lesional weeping, and she was, time and time and again, she was actually tested for genital herpes, which was, of course, negative. But on the resection, what we see is actually clear fluid-filled vesicles. If you look closely, I think you can make a diagnosis of lymphangioma just on the gross specimen. So these are the fish eggs, the so-called fish eggs. So just to convince ourselves and everyone else, and I remember I had a very interesting discussion with my more senior GYN pathologist disagreeing with my diagnosis. But we had to actually show that the tumoral DNA was actually, the lesion was negative for human papillomavirus. And we did this by PCR. As you can see, this is the 600 BP band, that's the beta-actin, that's our positive control housekeeping gene. And of course, all of these tumoral preparations, duplicates, are negative for the 450 HPV band, and that's our positive control. So it is not HPV, it was vulvar lymphangioma. And so the histology shows, again, these abnormally dilated, very superficially placed lymphatic spaces. Here's higher power. The lesional vessels do express CD31 and, of course, potoplanin. And here's very pretty. You can actually see this endothelial, papillary endothelial proliferation that almost resembles a valve. And all of the cells that are lining it are PROX1 positive. So now I wanted to switch to more from the malformations to just show you a couple of slides on how we use this information in tumorigenesis, the vascular tumors. So this is a 6-year-old girl with red-blue plaque on the face that we received. It's an excisional biopsy. Right at the outset, you can just, this is a very concerning biopsy. You can see that there's a lot of hemorrhage. There's actually loss of adnexa. You can see there's destruction of hair follicles. All of these hair follicles that should be lining up here, they're destroyed. And this extends very deep into the reticular dermis and the subcutis, this proliferative process. So when we look closely, we see that, again, a proteinaceous filled fluid in the lymph, some of the more, the vessels that are located in the periphery. But you can see this spindle cell proliferation that's almost, it's almost like a tight tumor nodule. In slit-like vascular spaces, you can also see hemosiderin. So this tells you that this is not just fresh blood, but there's also old hemorrhage here. And at this power, you can see more pink spots here, and that's actually platelet trapping, also called Kasabach-Merritt syndrome, one of the complications of capaciform hemangioendothelioma. So that was our diagnosis, and we used PROX1 to actually make this diagnosis. And I'll show you with my last slide how we came about discovering PROX1 for this specific entity. It was a very interesting story. So here we can see that the spindle cells are positive for PROX1, but the glomeruloid cells are actually negative. So this, I'm not showing you the data, but this was previously published, but it was a mouse model that we had made in the lab. We were expressing, ectopically expressing PROX1 in this capaciform hemangioendothelioma model. And when we did that, these tumor cells took off and they became more locally aggressive. And so that was the point where we decided, well, why not look at a human counterpart perhaps? And that's where we set up this study of looking at capaciform hemangioendothelioma, tufted angioma. It's been suggested that these two tumors may actually represent the same disease spectrum. And we compared it to infantile hemangiomas, pyogenic granuloma, and granulation tissue, which actually are included in the histologic differential diagnosis for this disease. So we had 75 tumors. We had both Dr. North, Sharon Weiss, many of you may know, and Dr. Mim on this study. So what was very interesting is that we found that both KHE and TA shared an identical endothelial immunophenotype. So we could actually demonstrate that these are in fact very similar lesions that may in fact do represent the same disease spectrum. So the spindle cells, you can see, they express PROX1. This is the PROX1 staining. They also express protoplanin live1, CD31, CD34 that I'm not showing here. But the glomeruloid cells were distinctly negative for PROX1, protoplanin live1. So this tells you that there's a kind of a confused, mixed expression of blood versus lymphatic. So we found that all the IH and infantile hemangiomas and pyogenic granulomas were completely negative for PROX1. And we suggested that PROX1 can be helpful in making that distinction, resolving that differential diagnosis. So in conclusion, I hope that I've convinced you that histologic examination and immunohistochemical stain are still very important in making the appropriate diagnosis. I know the imaging modalities are just off the roof. I mean, they're just great, but we still need to have perhaps biopsy or excisional biopsy, and with the combination of the immunohistochemical markers, I think we can make the appropriate diagnosis. And I hope that I showed the contribution of lymphatic pathology in vascular anomalies. And I think our study, which is not yet published, but I think it shows that vascular malformations are really truly a combination of both lymphatic and blood phenotype problem. And that this is published vascular tumors, TA and KHE, tufted angioma, and capaciform hemangioendothelioma are part of the same disease spectrum, and PROX1 can be helpful in resolving the differential diagnosis. Thank you so much for your attention.
Okay, we have time now for questions. We can start with Dr. Dadras up here, and Stan, if you'll come up and join me, so we can open it up for questions for any one of the panel of speakers. So, questions, anyone?
Hi, thank you for those excellent presentations. I'm David Hooksepian. I'm an interventional radiologist at Stanford. I'm not a plant, but I have a question. You showed in your presentations that there's pretty much every cell type and clotting factor conspicuously absent in lymph fluid are platelets. Why do you think that is?
Well, interestingly enough, if you think back to the slide that came early on in my first talk that showed once you have the polarity of expression in the cardinal vein, and then eventually you have a step that causes separation, the molecular agents that exert or secrete those molecular species are platelets. So platelets are integral to creating the separation between blood vasculature and lymphatic vasculature, with the ultimate, if we can think a little bit teleologically, the presumption being that we want the lymphatic system to be a non-clotting medium and retain the platelets all on the blood vascular side. So the proteins are there, but they don't have, even if they interact and cross-link to a degree, they don't have the cellular element to interact with to actually, create a true clot.
So just to follow up on that, though, thinking teleologically, you'd want, in the case of injury, to be able to clot and then remodel and heal. So that's kind of a setup for thoracic duct embolization, I guess. But so I'm not out of a job yet. But it seems interesting that those are absent, and yet the clotting proteins and all those other things are there. And we do see thoracic duct injuries or, tumoral invasion or a variety of things where actually clotting would be really helpful.
I think that, in my opinion, the actual clotting factors, because they're, I think, relatively smaller proteins, they're there as part of the passive flow. They don't participate in a lot of, so fibrinogen, of course, is an acute phase reactant, but beyond that, I don't think they participate in the processes that Dave was talking about, that where the character of the lymph is actually actively modulated in order to, I don't think they're there for that purpose. And I think, again, thinking teleologically, I think the lymphatic system is there to ensure and optimize as much flow as is necessary. You don't ever really want to shut off flow. Whereas in the blood vasculature, if you're in the woods and you get attacked by a bear, you sure do want to shut off, at least part of the flow so you don't hemorrhage to death. So I guess that's kind of a simplistic way of.
And to add to that kind of teleologic argument, of course, the pressures in lymphatics are order of magnitude and a half lower than what you see in nearby blood vessels. Even the veins, it's significantly lower, not an order of magnitude, but half an order. So you're not worried so much about massive lymph leaking out of a lymphatic vessel. And in fact, under the conditions, if you want to kind of speculate even further, that conditions where you would have some processes which are damaging tissues, whatever they might be, that in fact you need to by the lymphatic system providing routes of delivery of information to the immune system, you don't want to stop and block lymph flow off to it. And in fact, in one of the slides I skipped over when I was going over some of our IBD work, the only time we see clotting in lymph is either when we screw up somehow and get massive amounts of blood and platelets in our prep, or in IBD, we routinely see it. In the very small lymphatics, you will see clots formed about day 3 or so, where lymph is coagulated, trapping immune cells. And exactly how that occurred, we're frankly still trying to figure out. We're under the assumption that actually we're getting platelets from the gut wall when there's been dissociated small vascular problems within the gut wall, where the permeability of the vanules there has opened up so much. Now we're getting platelets coming into the lymphatics. We suspect that, though in fact we haven't proven that. The other time we see this is when we have, unfortunately, when we have a number of the diseases that are endemic to a lot of animal facilities. We're using a lot of rodents in our work. Parvovirus will clot lymph dramatically throughout the whole GI system. We don't know why yet.
That's a good treatment agent.
A quick comment. I guess as a pathologist, I've seen the presence of erythrocytes within lymphatic lumina and abnormal lymphatics within the anomalies. So I wonder if platelets also get in, but there's always this debate whether it's an artificial introduction of the erythrocytes into the lumina through the preparation, or is it they're actually percolating RBCs or perhaps even platelets?
I think a small number of erythrocytes are described as a contribution of normal lymph, but they're 1,000th or 1/10,000th of what you would see in blood. So there may be a little bit of, maybe through the lymph nodes, there might be some cross connection.
In the same line, in my clinical practice, we put external drain of the thoracic duct every month. And I can tell you that, and it's usually 4 or 5 French shifts going through the brachial vein to pretty much all the way to the cisterna cali. And this line is clogged all the time. All the time. I'm not sure what is that, and it's actually this discussion gave me an idea that we probably need to test what is this plugging inside the sheaths. number one. Number two, when we got in the thoracic duct of the patient with CHF, for example, it's always bloody. Bloody. It's not pure, it's very, very bloody. And the same thing Whitty and Alan Dumont described when they drain externally the thoracic duct for the patient with CHF and liver cirrhosis. Sorry, it's reverberating. CHF and liver cirrhosis, it's almost always bloody. And observation number three is blood is one of the best embolization material for the lymphatic system. So if we position in a situation where it's very dangerous to inject glue, we will inject blood, and it works very well. Or sometimes we cannot even get inside the lymphatic system. So what I will do, I will just put my needle and do what's called disruption, if it's, for example, leakage from a lymphatic mass, and it works very well.
Great.
Baby Lee from Washington, D.C. Enjoyed very much for the three presentations. I have two questions to Stan. You mentioned about anterior cardinal vein to start budding for the upper limb. What about the lymphatic system in the torso and lower extremity? Posterior cardinal vein, or how do you interpret that the budding toward the lower extremity?
If I understood the question was that if you said that the lymphatic system, if it arises from the cardinal vein, then
right. I mean, you know, we all know that from the venous system, it's budding out.
How do we?
And the Stan showed one slide, the anterior cardinal vein, and budding out. That's for the upper extremity, correct?
Yes.
What about the lower extremity?
Well, I mean, this is what I was, the two slides that I was, and of course, please jump in.
Yeah.
But the two slides that I was trying to show, you're speaking of the embryonic development of lymphatic system, correct? So there's at least two competing hypotheses. One is that, as Sabian had presented or suggested, that there are perhaps many of these primary lymph sacs throughout the human embryo.
That's right. So that's the point. You know, we are talking two different issues here.
Yeah.
When you look at the Austro-German embryology, the school, early data, they all explained based on just systemic sort of development here. But a low extremity, you know, we handle a lot of venous embryology here, but on lymphatic embryology on the low extremity, we don't have any document to support venous origin. That's my sort of a dilemma we have here.
I think the venous origin, of course, we have to presume that mammalian development is replicated throughout the evolutionary tree because we've studied it in the mouse, not in humans. But at least in murine embryology, with using molecular techniques, everything seems to support Sabin's hypothesis as opposed to a circulating lymphangioblast origin with multicentric development. So at least in the mouse, the primordial lymph sac starts in the way that was shown and then is distributed through the body in an axial manner.
Right, so since I saw you having anterior cardinal vein,
Yeah.
I was kind of encouraged to ask you, can I just use the same rationale for the lower extremity posterior cardinal vein, like a venous, primordial venous system? Can I do that? That's my sort of wishful thinking, but nobody ever documented for the lower extremity. Like upper extremity, all the data you just mentioned is based on the the animal model there, but in the lower extremity, we didn't have it. And anyhow, I was wondering whether I can just extend a little bit from your quotation of anterior cardinal, why not posterior cardinal vein?
Again, the murine studies are what we have to go on, and I think what has been very mechanistically encouraging to modern thinkers is that using the most sophisticated immunohistochemistry that we have today, we came up with the same thing that Sabin did with India Inc., a century earlier. It was debated through most of the 20th century, but eventually with immunohistochemistry, it looks like it's replicatable.
All right. One quick question. Somebody like a Waldemar Olszewski, denies that the well-documented sort of information, the literature, saying when you do intermediate pneumatic compression, mobilize all the fluid, the protein concentration at tissue level is supposed to be high or normal or low. But all the literature said high. But according to Waldemar, his personal sort of evaluation, that protein concentration is the same. So which one is affected, which one is a myth? Protein concentration at tissue level following intermediate pneumatic contraction.
So the only person to my knowledge who has actually attempted to sample those fluids is Olszewski, at least in the human setting, and I'm not sure if there are mammalian
so
studies like that.
So how do you think? It's a normal, higher?
Well, I think the operative principle, what happens at the tissue level itself, within the interstitium, that's very difficult, to document. But I think what sometimes introduces confusion is that in the early literature, people talked about lymph as a high protein concentration body fluid. And the fact of the matter is, protein concentrations are less typically than what is in circulating blood, but it is more than what would be present in an ultrafiltrate, for example.
We should stop saying that high protein concentration.
It's a protein-enriched body fluid, basically. I don't know if you...
And to add a little bit to that, because we've actually done some proteomic analyses with Dr. San Ambrosio, so it's skewed protein concentration as well. So as opposed to an ultrafiltrate, which tends to have a lot of the large molecular weight, even though it's at much lower concentration than what it is in plasma. For instance, albumin is down around 1-2% typically in mammalian lymph, as opposed to 5 to 8% in plasma. But if you look at the smaller molecular weight compounds, still large molecules, macromolecules, but these are breakdown products from your cells. There's a lot more of them that's in lymph than what would be an ultrafiltrate from a pure venous or capillary exudate. And so it does get changed, and it modifies. It's different in different tissues depending on the typical activity of the local parenchymal cells. So there's subtle differences, but in the answer to the question is it's still much, much lower on average, the protein concentration in almost any lymph, except perhaps if I could sample what that clotted lymph was in those lymphatics, that might be higher, but otherwise it's much, much lower than what you typically see in plasma.
Thank you. I was at the World Congress of Lymphology just a few months ago, and there was a presentation by Dr. Bruno Cicli that had several slides that showed a possibility of a vessel within the lymphatic collector. And I'm just wondering if you would comment on that, and if it exists, and do we know what the function of that might be?
Did you hear?
We couldn't
There's
understand.
a lot of reverberation. Can you
Oh,
repeat it?
I'm
Just
sorry.
stand back a little
Okay.
from the microphone.
At the World Congress of Lymphology a few months ago, Dr. Bruno Cicli had a PowerPoint presentation. And he had several slides showing what looks like a vessel running inside the lumen of a collector. And I was wondering if you had any comments on that structure and what the function might be of that structure if it exists.
So these have been, Dr. Cicli was in the first one to describe them. They've been described for a few decades now. They're small tubular structures. I hesitate to call them a vessel because it's not clear that they actually have a lumen, or if they have a hole in them, it's definitely not clear that it's continuous. But there has been a lot of evidence from lots of folks before that there are these small, let's call them tubes, that lie inside, particularly this very small lymphatics, and they've given various names. At first I didn't think they existed, but after looking at the literature, it's pretty hard to debate the fact that they exist. What they are, what they do, where they come from is not very clear at this point.
Okay, thank you.